Hi, my name is Nadira Hamid, and I'm one of the interventional echocardiographers from Minneapolis Heart Institute. And thank you for joining me. And today is an exciting day that I'm at TCT, together joined with Dr. David Daniels, one of the PIs who from the Encircle trial of the SAPIEN M3 trial. And this is so exciting. And first and foremost, who's going to talk to us more about it, congratulations.
Thank you so much. Yeah, it's great to be here in my hometown of San Francisco.
Oh my gosh.
And it's a really exciting day. And we couldn't be more thrilled to be on the launching pad to first present the primary endpoint for the Encircle trial.
Absolutely. I mean, it's the first percutaneous transseptal mitral valve replacement, the balloon expandable, the SAPIEN M3. And you'll be discussing on the one-year outcomes during the presentation. Take me through, and the audience, what are the key findings of this trial?
Yeah. So, I mean, I think just taking a step back and looking at what it is, I mean, you just said the first percutaneous transseptal transcatheter mitral valve replacement to reach its primary endpoint in the world. I mean, it's, you know, honestly, that is an amazing thing to have been a part of and to be part of the journey. We have so many patients who really don't have good treatment options. That's patients who have severe mitral regurgitation, who are symptomatic, who are not good candidates for surgery. And unfortunately, not everybody, as you know, is a good candidate for TEER. And this is a patient population which we've all struggled with, right? It doesn't mean that because there's no good treatment options, it doesn't mean there's no treatment options. So we treat them with intervention, you know, and medications and CRT and whatever we can treat them with. But when it comes specifically, when we drill down to interventions, we're really talking about surgical repair replacement or TEER. And those patients who aren't good candidates sometimes get it because it's a last resort, get one of those two therapies. And we've all learned through the school of hard knocks, you know, that sometimes those outcomes are not what we would hope for. So I think transcatheter mitral valve replacement, and that's really the population of patients that we study. When we looked at it, it was really interesting because I think up until this point, from a transcatheter perspective, the outcomes, even in patients who are frankly good candidates for TEER, they're not what surgery is, right? We all know that, right? I kind of give an analogy of PCI versus CABG, right? PCI is less invasive, it's convenient. In some cases, absolutely life-saving, but in many cases, especially in patients with complex disease, it doesn't rival CABG as far as the outcome. And we all know that. The data supports it, our experiences support it. So when we sort of pivot to looking at the structural heart world, I think you can make a similar analogy to TEER, right? It's not as good as surgery, repair, replacement with respect to acute reduction in MR, well established, well understood. It also is not necessarily as good with respect to longer term outcomes, but it is less invasive. So there's that sort of equipoise for many patients, right? Now let's take a lesson from aortic valve replacement, right? And think about when TAVR came onto the world stage. Right?
Yeah.
We had, for the first time, an intervention in structural heart disease that rivaled surgery, both with respect to acute outcomes and with respect to medium to long-term, outcomes. And we're going to see some of that data this TCT in terms of the 7-year outcomes for PARTNER.
That's right.
But I think that, you know, when we look at TMVR, we really, in my opinion, for the first time, have an intervention on the mitral valve that rivals the outcomes of surgery. And we do it, you know, with the same minimally invasive approach that patients and referring providers appreciate and really benefit from when we like TAVR, right, compared to surgery. And then the outcomes with respect to mitral regurgitation and improvement in mitral regurgitation are really surgical-like.
No, that's precisely, you explained beautifully why you and the team did this trial.
Totally.
And, you know, with the landscape of TMVR, we know how many devices were out there and who tried and failed. And finally, we got something.
Yes.
And how can you tell the audience out there, what are the kind of patients, you know, and your experiences during the trial period? What are the, you know, things to look out for in screening? As we know, imaging is a key part of the screening and during the procedure to look out for hopefully when this valve gets commercialized. So what can you tell us?
Yeah, so I think that's a great place to start, right? So start at the beginning. What's the patient population that we're looking at, right? And how do we really select patients appropriately. So when we embarked on the Encircle trial, we really learned from our early feasibility experience. And I think this is a journey which all devices go through, right? And I think it's a really great thing that we do is going through an early feasibility study, all the learnings about the device technically and the screening, and then we apply those to our pivotal studies. So what I would start with is that, and this sounds a little silly, but I think patients have to have severe mitral regurgitation, right? I mean,
Of course.
It's kind of funny, but, and I'll tell you, not every patient submitted for the Encircle trial, despite the investigator's belief, had by the core lab severe MR, and that's okay, right? I mean, MR is, as we know, more difficult to assess,
and
right?
Dynamic.
It's dynamic,
Yes.
and its severity. It's not 4 meters a second, right? It's a bunch of other things. Frankly, I'll say the first thing is we all learned a lot, right? We learned from core labs like yours and others how to be better at making the diagnosis, right? And I think that sounds a little silly, but I think it's important for us to sort of admit that, right?
Yes.
So I think that's the first thing. Make sure the patient has severe mitral regurgitation, because you really want to get to risk versus benefits of any intervention and make sure we're following in the right range. So that's the first thing. The second thing I think is looking at, one of the great things about M3 is that we treated patients across the continuum of etiologies, right? Both primary and secondary MR. And though we in the presentation we look at what those baseline characteristics were, we saw significant and equivalent improvements in both those etiologies. So we really have a therapy that can be applied both to degenerative primary or secondary functional MR, and I think that's important. Like any transcatheter mitral valve replacement, or like any device, there are going to be exclusions, right? There's going to be patients that fall outside of what we currently understand to be a reasonable application of the technology. With respect to M3, one of the things that was amazing about the trial is, despite clinical exclusions, like, well, the MR wasn't severe enough, or, the patient couldn't tolerate anticoagulation, or other things like this. One of the amazing things is, unlike any other mitral valve replacement technology I've ever seen, the anatomic screen fail rate was only 35%. And I think many other studies are 70, 80, 90%, with respect to one of the biggest issues, which is LVOT obstruction risk, right?
Correct.
So M3, because of its design, has a anatomic screen fail rate of only 35%. I think it's really, really impressive.
That is absolutely, compared to the other TMVR, the whole history, and there's so many devices out there for TMVR, and now it's down to, I think, 3.
That's right.
2 of them are in trial, and yours is the first percutaneous transseptal, transcatheter mitral valve replacement. And what you said about the imaging is really critical. The pre-screening of the quantification of mitral regurgitation, which we still are finding it challenging because of the dynamic process. What do you think your experience with the trial, the learning curve for operators and imaging? As we know, procedural imaging is key for the success of any procedure. So what are your takes from this, from this device, that we can tell the audience who are eagerly waiting for this device to get their hands on it?
Yes, I know. I think a lot of people are eagerly awaiting it, and we're eager to get it out, right, to the community and to patients worldwide.
Correct.
I've been involved with the SAPIEN M3 system, with Edwards Lifesciences from the very beginning. And, even at the beginning of the early feasibility study, I think one of the great things about this journey has been a phenomenal partnership between physicians who are really interested in innovation and how to improve how to proceduralize the procedure, as I like to say. So I think we learned how to teach the procedure. And I had the honor to spend a lot of time going out to different hospitals and proctoring them through their first cases. Great. And at the same time, in parallel, and I would say in great collaboration, the amazing engineers at Edwards Lifesciences work to improve and facilitate making the procedure easier to do and more efficacious. So I'll give you an example.
Yes.
When we first started doing the M3, it was sort of known as this procedure that took 4 hours, and it was completely painful. I mean, to be
That's
very
what
honest,
I heard, yes.
To be honest, you talk to John Webb, who's become a good friend, and like most devices, John did the first, and it was a different beast. And I think I'll just point to one improving it from a procedural efficiency perspective, it was the addition of a hydrophilic sleeve over the dock. So, as we know, and we can show the animation maybe, the encircling of the cords is a nitinol dock. The current iteration of for the device has a hydrophilic sleeve, which decreases friction, right? Because you can imagine as you go around the mitral apparatus, by the time you get to the third turn, friction can build up. So the hydrophilic sleeve was a great addition from the Edwards engineering team that allowed that to be a lot more efficient and a lot quicker. And we can show even a fluoroscopy of how quick it can be in real time. Then the sleeve is removed so that the dock locks itself in there. And then I think another, from an efficacy perspective, one of the amazing innovations was the addition of a paravalvular leak guard. So it's sort of obvious that our dock, transits from the atria to the ventricle, has to get there somehow, so it goes through the medial commissure. And early on, there was an increased incidence of paravalvular leak through that medial commissure. So the engineering team dreamed up a plug on the dock, so to speak, that was preset as a paravalvular leak guard. So, and those things continue to improve. And as we look at the outcomes data, we always want to be better. And I think, we'll be seeing a lot more improvements in the system moving into the future.
That's fantastic about the paravalvular leak. And I'm curious, is there anything pre-procedural in the TE to say, hey, we need to prep this up, in advance to the procedure?
So one of the things we did, in the trial, and I think it was out of an abundance of caution more than anything else, is really be careful about enrolling patients who had significant degenerative disease in the medial commissure, because that was going to be the weak spot. And I think that's an important caveat when you ask, what are patients that we want to probably steer away from, at least early in the commercial experience. It's patients with significant degenerative disease in the medial commissure. I would say that, one of the amazing things about M3, and I think TMVR in general, is the ability to treat patients with secondary MR who often have significant ventricular dysfunction, right? There's a few things about the device which I think, we are still in our early understandings of the why, but the idea that it's a relatively small footprint in the basal LV, the idea that we pull the mitral apparatus in, and there may be some mechanical effect, and I'd be very curious as to your insights on that, as an echocardiographer. I will tell you clinically, as somebody who stands at the table doing these procedures, oftentimes in patients with EFs of 25 to 30%, those patients go to surgery, they're coming out on 5 of epi, maybe a balloon pump, and so our honest to goodness experience, time and time again, treating those patients, is they didn't flinch. They were not on inotropes coming out. They did not go to the ICU. And that's very different than some of the reports and some of the experiences in other TMVR systems that may be larger, that may affect the basal LV mechanics more, and for whatever reason, come out of the cath lab on inotropes. I think it's a huge difference. You come out of the cath lab on inotropes and or balloon pump going to the ICU, no matter what else you do, you're more of a surgical-like procedure, in terms of the outcome of the procedure. And I think, something about the M3 system, and we're still learning, but I think it may have something to do with its footprint, is really allowed us to treat patients with very low EFs and that have really an unremarkable clinical course.
I love the fact that you said about the small footprint, and I'm very curious as to your point as an interventional echocardiographer, the left ventricle remodeling for this group of patients. I think, and then it enable us to screen these patients earlier, whether with advanced cardiac imaging, with cardiac MRI, the presence or absence of LV fibrosis, which we've seen in the literature, as to when to intervene these patients early on, and the fact of elimination of the mitral regurgitation. I think with, finally with, the M3, the TMVR, once it's out, I think can help with, your experiences and your thoughts about the durability of mitral regurgitation with the current platform. And so we as interventionists and, imagers, when at valve meetings, be able to discuss which therapy works best really to eliminate mitral regurgitation rather than leaving some residual mitral regurgitation. What are your thoughts about that?
Oh yeah, I got a lot of thoughts on that. I think, let's just pause for a second. You and I think together. Have you ever seen even a case report or a series on patients getting M-TEER that show significant reverse remodeling of the left ventricle? It's really not something that we talk about. Not in a maybe there's a case report somewhere. I don't know. Let's look. But in terms of case series or large, descriptions of that, it's not something that we see. And certainly I don't see it in clinical practice. Why?
Yes.
It's probably because we don't eliminate MR to the degree that we would all like. And we can all look at the registries and look at everything. But I mean, listen, at the end of the day, the 12-month outcomes, buried in the supplementary appendix for the co-op trial showed a 30% rate of moderate MR, right? I mean, we're not doing the same thing as we would with surgery. So one of the great things to see in this experience was when we significantly reduce MR, and I would say near elimination of significant MR like we saw in the Encircle trial with greater than 95% of patients having mild or less MR.
Wow.
That was seen and sustained through 1 year. That a correlate of that was a significant, in a paired analysis, improvement in left ventricular end diastolic volume index. And we don't see that in MTR, right? It's really, and that was just within the first year, right? And it's really, really exciting. And I remember early on seeing these echoes at 1 year and calling up Edwards and saying, you're not going to believe this, right? This person's ventricle shrunk.
Wow.
And I think, that's really important also because as you know, the treatment of the mitral valve and the tricuspid for that matter is really even much more of a team effort than the aortic, right? It involves interventional imagers in the case with us, but it also involves advanced heart failure specialists, right?
That's
as we both prepare our patients and manage the patients through the course of their procedural hospitalization.
Absolutely.
What I can tell you is I haven't seen advanced heart failure doctors get more excited about a mitral valve technology than they are at this. I mean, one of the guys just yesterday in the hall said, Dave, I'm so excited you're presenting the Encircle trial. I love that valve. I love that valve. Every time one of my patients gets that valve, they just do better, right? And this is, an anecdote, but it's the feeling, and I think the data reflects it.
And to your question, the next one, and I know the trial has 3 arms, so you're presenting the main study.
Yes.
What can we look out for with regards to the 2 arms?
Yes.
I believe it's the MAC registry and the failed TEER registry.
Yep.
What are things that you could tell me and my audience, what we can look out for in the future?
So the data is not yet published, but we have completed enrollment in the MAC arm. We also had pretty significant enrollment in the failed TEER registry. And I think maybe we start with MAC. MAC is, and we sort of joke of if it's Myra Mac or Little Mac, right? And those of you will understand the joke. We're really talking about primarily MR with MAC, also mixed moderate, so moderate MS and moderate MR and or severe MS. But in general, these are patients that aren't what I call Myra Mac, aren't the big Mac, the SAPIEN M3 and valve and MAC.
Right.
That's a different population of patients, as we all know, and pretty sick and complicated. But we oftentimes have patients who have significant MAC that really just aren't good candidates. Not impossible, right? We all know we can do an M-TEER and that's fine, but not good candidates for the ability to achieve significant reduction in mitral regurgitation, right? What we would call significant reduction. And they're more complicated for surgery too. So I think the MAC registry was really, really important in looking at those patients. We also see some patients, who are rheumatic, and just to have note, we didn't exclude rheumatic patients, right? So we saw patients with rheumatic heart disease that oftentimes had some calcium, right? And they certainly would never have been candidates for an M-TEER. I mean, that's like in the red, right? And we saw, our experience with that has been really, really interesting. And I can tell you, at least anecdotally, we've been really, really happy. So I'm excited to look to see that data published. And to add that to our indications for patient populations that we can treat.
Oh, absolutely. I mean, we see a huge population of rheumatic mitrals in both our clinical practice and with no options.
Yes.
And so I'm excited to hear more of your experience about this.
Yeah. One thing I'll say, sorry, is that the M-TEER, failed M-TEER. So, I think it's an interesting population to look at. I foresee, I think even I want to make the point, even today, right, with all of the things we've learned, right, from an imaging and interventional perspective, sometimes we get in the lab, we're going to do an M-TEER, and we said, oh, yeah, this is just, I had no idea. It's just not working, right? We put one device on right in the middle, and we've got, all the way across
Yep.
MR, and the
Yes.
person's mitral valve area is 3.8, and the gradient went from 2 to 5, and what are we doing here, right?
Yes.
I don't. This is a plea to the business people and the decision makers at companies like Edwards Lifesciences. I really think we need to think everything in cardiology, in the structural heart. We always do better when we think like the surgeon, right? We always do better when we have the tools that the surgeon has.
Right.
When we think, I've learned so much. We all have so much from our cardiac surgical colleagues, right?
That's right.
And at the end of the day, what I think we should all try to make very possible is that we can go to the cath lab, and at times we can do, the procedure can be called M-TEER, possible TMVR, right? And I think that there is absolutely a reason where we may go and we may say intended repair, but possible replacement, right? Just like the surgeons does, right?
Yes.
And I think that's really important. So if there's a way for them to make that financially feasible, I think they can, right? Because I think it'll be a small percentage of patients. Most patients you go, you try to do an M-TEER, great. You do an M-TEER and it's a good outcome. Most patients you go and, you're really off the bat going to do a TMVR for X, Y, and Z reasons. It's going to go well. But I think there's going to be a percentage of patients where we want to apply M-TEER for various reasons, but it's not going well. And we need to be able to flip like the surgeon and repair, possible repair, possible replacement.
I absolutely love that idea because I have experience of patients on the table where we have to abandon due to various reasons that you mentioned, leaving substantial residual mitral regurgitation versus increased gradients due to the...
Versus aborting the procedure. And, nobody wants to abort the procedure because you want to help the patient. How great would that be? That we could go and try, and then if it doesn't work,
switch to therapy.
Strategies, and that patient leaves the cath lab with no MR.
Absolutely. Instead of extubating the patient and then rescheduling, I think the hospital resources
For sure.
I think gets impacted by that.
Right. Absolutely.
I love that idea. And hopefully in the future we can see that.
I hope so.
And final question is, what do you see the future of this device in this TMVR landscape?
Yes.
What do you think will happen? And if there is other further reiterations of this device that we can, look out for and to attend to various, as you know, the anatomical variations of mitral valve.
Right. So that's a lot to unpack there. I'll start at the beginning. I am excited beyond words.
Okay.
To be able to be part of a journey which has given patients an option for lifetime manager. And we talk about, lifetime management has been this sort of, catchphrase in the treatment of aortic stenosis for a couple years. But even, I'll tell you, at the very beginning, the moment I saw this device, and one of the reasons I was so passionate about being involved in any way I could be, right? I said, I'll do whatever you want. I want to be involved with this journey because I saw the potential for this to be an iterative step, a disruptive step in the ability to give our patients an option for lifetime management. And this is what I mean by that. You have a patient who gets an M-TEER. They get 2 devices, secondary MR, right? Very common. And result is, okay, mild to moderate, symptoms improve, and then they come back 2 years later, ventricle's a little bit bigger, or for reasons that you may not even be able to understand, you got MR coming out all 3 orifices, right? And the patient's very symptomatic. And that person's really, really, really doesn't have any option at that point besides transplant or an LVAD because, going to surgery then is gonna be very high risk. So if you translate that experience to a TMVR, we have near elimination of significant MR at basic. We have a statistically significant improvement in reverse remodeling, which is gonna improve the patient's outcome based on other data. And then at the end of the day, though, it is bioprosthesis. It's going to wear out at some point, right? Nobody's going to say it's not going to wear out. But when it wears out, the procedure to intervene is akin and, frankly, in my experience, easier and simpler even than a surgical mitral valve and valve, right? And a procedure that can literally take you 20 minutes to do, and you reinvigorate that mitral valve to normal. And if you think about it as an imager, I will tell you this. Think about the challenges that we're all facing right now, right, as we come to the early failures of, or not early failures, the late failures of the earliest implants of TAVR valves, right? So we're all starting to get this experience, right? 8, 10, 12 years out, we've got to do a redo TAVR. Well, We've got coronary risk plane issues, right? We've got sequestration issues. We've got real risk, right? And how to manage, and hence, modification devices. If you think about the mitral space, and especially with the SAPIEN M3, I think as the prime example, we've got a device that's small, right? That there's really no structures outside the device, that if we push that valve just a little bit farther out, right, with an overdilated balloon, and then put a new SAPIEN, probably SAPIEN 3 inside of it, we own all of the LVOTO risk up front, right? Because it's a full frame PET design, so there's no extra obstruction that would happen. That's very different than like a surgical mitral valve. And so there's no risk of LVOT obstruction. There's the ability to expand everything a little bit and really achieve, nominal diameters again. I mean, this is not an Edwards position, but I believe that we can do, honestly, 3 to 4 TMVRs inside of an M3 and get a patient through their life with it. This is very different. It's a transformative and disruptive time to be involved in mitral valve interventions.
And that's a good way to end it, because that's how we should change the mindset of treating the landscape of mitral regurgitation. Right? Complete elimination of mitral regurgitation. And I think this device and maybe other TMVR who will come into the market with their trials can help change the mindset as we, discuss patients at valve meetings.
Exactly.
Where TMVR is the first option.
And to be honest with you, and I would say the thing is again, look at that PCI to CABG analogy that I talked about.
Exactly.
Right? And that TAVR to SAVR, right? How that we leveled the playing field. The thing is that TMVR and surgical mitral valve intervention, we level the playing field from an outcomes perspective in terms of elimination of MR. But we do 2 other things. One is we offer, like TAVR, a truly minimally invasive, fully percutaneous procedure that can be done in an hour, and the patient can go home the next day, like TAVR. Second, and I think it's really notable, even in this early experience, that when we looked at the predicted risk of mortality of our patient population via the STS calculator of 6.6%, 30-day mortality, and the outcome of our trial at 30 days was 1/10 the mortality predicted in surgery in our population. That's really powerful.
That is really, really powerful, and it speaks volumes. And now I cannot thank you enough and congratulate to you, your other co-PIs, and the team from Edwards for putting, for doing this trial.
Yeah, it's so important.
So important.
I feel so honored to be a part of the journey.
And a huge congratulations to you and the entire team. And with that, we'd like to thank all the audience for tuning in, and really looking forward to the next phase in the landscape of TMVR with the SAPIEN M3. With that, thank you very much.